criteria be one ST elevation of 1 millimeter or more, 1 millimeter or more, and 2 contiguous leads. But the 2013 recommendations came out from American Heart and the American College of Cardiology, and they changed that to 2 millimeters in B2 and B3, and then 1 millimeter in all other leads. Now, I always say that if you see ST elevation even of 1 millimeter, there's something going on. It's better to be more sensitive to the elevation than specific, meaning it may not be an acute MI, but at least you're having somebody take a look at it and get the right people involved. So I prefer to stay more specific or more sensitive to the ECG. This is a big one here. The next bullet, reperfusion therapy, is indicated, meaning they need to have an intervention, even if they don't have pain, because a lot of these patients come in and they may not have pain. They don't have chest pain. They might be diabetic, female, elderly people. I had a patient come through our ED just the other day, and they had a long durable balloon time because they didn't have symptoms. She went to bed with chest pain at 3 a.m. She woke up, she had a little bit of recurring chest pain, but it wasn't significant. She did go into a clinic, and the clinic did an EKG. There was ST elevation there. They weren't comfortable with her status, so they transferred her over to our ED. And she sat in our ED. It was 18 minutes before they did the EKG. But then they even consulted cardiology. Cardiology didn't know whether they should take her to cath lab because she wasn't having pain. She ended up having a long durable balloon time because, she was diabetic. She was only 69, but she wasn't having chest pain. And it's like, these patients may not have chest pain. That is the presenting symptom that we all are used to asking about, but it doesn't always have to be there. So I just want you to be aware. They may present with other symptoms, but and the other thing that is important is if you are concerned about them, make sure you're doing serial ECGs. We actually recommend if they come in with chest pain and there's no ST elevation there, or they come in with some other presenting symptom that you're concerned it might be acute MI or ACS, do ECGs every 10, 20 minutes, whatever you feel is appropriate. It's very important because it will evolve. The ECG will evolve over time. Whoops. I gotta go back. Okay. STEMI obviously stands for ST elevation MI. We know that early diagnosis and rapid reperfusion therapy is very important. It limits the size of their infarct and it improves their survival. And there's many, many studies out there that prove that, it's crucial to get these patients treated either with fibrinolytic therapy or with PCI. So the current guidelines recommend a reperfusion therapy of within, door to balloon, less than 90 minutes. And now we've moved to first medical contact, meaning whoever sees that patient first, whether it's EMS, a clinic, anybody that's able to provide care, a medical person that can provide care. We've moved to that. We've moved away from just door to balloon. It's now community to balloon. So first medical contact to balloon, less than 120 minutes. And I can tell you that not many patients are receiving that kind of treatment. That's why there's a lot of initiative going on with the AHA, Mission Lifeline, because you can see only 33% of the time are we meeting that less than 90 minutes for transfer patients. Meaning patients that are transferred from Osage to Mayo, only 33% of those patients are receiving door to balloon time less than 90 minutes. It improves a little bit when you move the benchmark up to 120 minutes, then we see about 66% of the time those patients are receiving appropriate care. So it is a big deal, especially when you think about the mortality. 2 out of 5 patients will die within a year, so. I'm going to talk a little bit about Mayo's fast track to STEMI protocol. So I gave you guys the protocol there. Does anybody have any questions? Again, I just want to ask. ECG changes, any questions about anything? Q wave MRIs, symptoms? Are we bored to death?
No.
Okay. All right. So yeah, and I'm going to talk about our protocol, but I want you to know that wherever you send these patients, it needs to be quickly, and it doesn't matter. Just know the protocol, whether it's ours or somebody else's. Know how to, know what your plans are and where these patients need to go. So. Obviously, this is our protocol. It may look familiar to you. I have posters. I don't know if you guys have one up here or not. Doesn't matter, but let's just break this protocol down a little bit for you so that it makes more sense, because there's a lot of information on here. So what you need to know is you have this patient that comes in. They're having chest pain. What do you do? So important things are to have somebody at registration. I don't know if there's somebody at registration all night for you guys or not. It's just the nurses, know what you're looking for, and get a stat ECG. Get the ECG as quickly as possible. And then I don't know how your process works here. I don't think your physicians are in house all the time, are they? So most of the time. So obviously you're going to want to be, you have a little bit more to deal with. You're going to have to get a hold of the consultant, right? And they're going to have to make the decision and determination. How do they look at the ECG if they're not here?
They have to be here in 20 minutes.
They have to be here in 20 minutes. So you guys are really the first line of defense for these patients. I mean, if you think that you have a STEMI, it's going to be you guys that have to do something with this ECG. So my recommendation would be, you do the ECG, you're concerned about it, right? You can always fax it to St. Mary's. There's no harm in faxing that ECG. That number will send the ECG to the CCU, and it actually goes to an email box where the consultant that's on call will review it, okay? So that's a pretty nice backup plan for you guys if you have an ECG that you're just really worried about. Fax it over. Nobody's gonna care.
Do we have to call first?
No, just fax it.
And what's the area code? 507?
Yeah, I'm sorry, yes, 507, yep. Fax it over, they'll take a look at it. At least they'll know that something's going on. And usually if it looks like it's a concerning ECG, you'll probably hear from the consultant. You'll probably get a call saying, "Ooh, this doesn't look good." So I would definitely recommend, if there's an ECG you're concerned about, faxing it over if they would be coming to us. Or even if they're not, it doesn't matter where they're going. It doesn't matter where they're going. We just want somebody to review that ECG. So once the consultant is on board and here, then he'll make a call to this nurse referral line, and they will connect him or her with the CCU, and that's the consultant. The two doctors talk back and forth. You guys probably know this. They decide what treatment is needed, whether it's fibrinolytics or transfer for PCI. And usually if you guys haven't called for transport already, they'll get transport on the way. So the nurse referral line will arrange both if you haven't done so. You can call for your own transport, but if not, they'll do that when you call the nurse. Does that make sense so far? Yes. Alright, so this is the bottom part of the protocol, which on this side here, I think there are, I know there was for me anyways, a lot of questions about lytics. It's kind of a scary thing. And primary PCI is the preferred method of treatment for STEMIs. When we can get them there, to balloon within 120 minutes. Now, if you know there's going to be a delay, and it might be weather, it might be the fact that there's no helicopter available. It might be that the patient's preference is to go to a further away PCI center. Can you give them lytics? The doctor's going to review that, and most likely with the help of the consultant that they're dealing with, they'll decide on whether they're going to give lytics or whether they're going to transfer to PCI. So what we look at is the symptom onset. So if a patient comes in early and they've only had symptoms for a few hours, and they're like, yeah, I woke up at, it's now 8 o'clock, I woke up at 6 and I had this chest pain. Well, they're presenting fairly early. The doctor then has the option of giving them lytics. So I don't know what you guys have here, but TNK, Retaplace, yeah. So we have TNK on our protocol. It doesn't matter whether it's TNK or anything else that you guys would have had, but so if they're presenting early and they have the option of lytics, we would choose this pathway, okay? And that means that you give them lytics, full dose lytics, which usually ends up being about 50 milligrams of IV push. And the goal for that is that you want to be able to administer that lytic within 30 minutes of their arrival time. So they show up, you get the ball rolling, you make a decision, you give the lytics within 30 minutes. And then the adjunctive medications are going to be the heparin. Obviously, you're going to start heparin. You're going to give them Plavix, 300 milligrams of Plavix, so half the dose of a PCI patient. And then those patients will be transferred, but they don't always go for PCI right away. Usually what happens is they'll show up, they'll end up in the cardiac care unit, they will get another ECG, the doctor will evaluate the ECG, the symptoms, the resolution in the ST segment elevation. If they're still having pain and there hasn't been a lot of resolution of the ST segment on their EKG, they'll probably go for PCI after that then. So they don't always go for PCI after lytics, but they'll be reevaluated once they get there. Some patients I've seen complete resolution, chest pain free, don't end up going for PCI. It's incredible. I mean, they'll have a follow-up angio just to make sure that the arteries are clear, but they don't always go for PCI. So it works. Little caveat to our pathway there with the lytics is patients that are over 75 years of age are more susceptible to bleeds. So with those, there was a study that came out that recommended giving half-dose lytics to patients that are over 75 years of age. And again, that should be discussed between your consultant here and the consultant where you're transferring the patient. The other arm of the pathway is obviously the primary PCI. Those are for your patients that would probably show up that can get to the cath lab within 120 minutes. Not going to give lytics. You're going to give the heparin just like you would. Plavix probably here. I don't think you guys have ticagrelor here.
Yeah, we do have it.
Well, you do?
Yeah.
Okay. Either way, there's a little bit of difference in the onset of action between ticagrelor and Plavix, but a lot of our referring hospitals don't stock it, so they still give Plavix, and that's fine. It's a dual antiplatelet, and it's going to suppress the platelets, try to prevent more of that clotting buildup that's already going on. The adjunctive medications that's actually up above is the aspirin and the nitro as needed. Be careful giving nitro to patients that you think might be having an inferior infarct, right-sided. It can cause them to go into more heart failure because you're going to dilate everything even more than it already is, and their pressure's going to drop on you. So Couple things to ask yourself, obviously, is this a STEMI, are we gonna activate the protocol? When the physician calls, it's good if they can be as clear as possible, if they know it's a STEMI, and they're calling me, referral nurse, encourage them to use the words, I have a STEMI, I need to activate transport. Obviously, you wanna make sure that they're not DNR or DNI, okay, we've had some patients show up that were, we were able to reverse them when they got there, they said, yeah, I'm gonna, we'll go, I'll reverse my DNR, DNI status, and they ended up going to the cath lab, but, you can see the labs that are listed there. I don't spend a lot of time emphasizing the labs because I want you to get the EKG and I want you to get the ball rolling. You can do the labs, you can review the labs, but don't let that hold up your transport. If you don't have labs back yet, doesn't matter. The physician that you're talking to, that the doctor is talking to, should really be focusing on the symptoms and the EKG. They can fax over the labs later. You can fax over the paperwork later. Just expedite the care of the patient to get them out as quickly as possible. We can get the information that we need later on. And I want the nurse referral line also to ask as few questions as possible. I know that's been an issue in the past where there's a lot of questions that get asked and they might be on the phone for 10 minutes and we need to get the helicopter in the air or ground transport and get the patient moving. So does anybody have any questions on this part of the slide around lytic therapy or adjunctive medications, anything you've seen in the past? Not a thing.
What if your EMS does an EKG in the field and that shows your elevation right there? Can I just fax that one from EMS without
say
even
yeah.
doing one? Okay.
Yeah. Yeah. If it looks, if their EMS is fantabulous, they're awesome, right? They are our first line of defense, and we meaning AHA, we know that in order to meet the recommendations from Medicare, Medicaid, just the national initiatives that they're trying to push, to improve patient outcomes, the only way we're gonna be able to do that is to incorporate EMS into the, EMS and then community initiatives to get them to call 911. Half the people that show up at our door, only half call EMS. So there's a lot of community effort going on with the AHA to get people aware of the need to call 911 when you're having chest pain. You don't have somebody drive you, you don't drive yourself or take a taxi. We've seen it over and over again, but EMS is crucial to this. So if you have an EKG from EMS, fax it over, absolutely. This is just a picture of an angiogram. I will send a full report back to the hospital when I review a case. What I do is I'll put all the time metrics in there, and then I'll put the ECG and the 2 pictures of the pre and post angio. So this is ST elevation in the V leads. So it's an LAD, left anterior descending occlusion. You can see the pre-angio. I don't want to block the thing, but this obviously right here and that. After they opened it up, you can see there's still maybe a little bit of an occlusion there, but it's pretty amazing when you see the results. Some of these angio, some people really come in, there's absolutely no blood flow at all. So.
And you send this back to the hospital that referred the patient?
Yep, so, I think there's a slide in here about what metrics I actually collect. I think if it's not in here, I'll show you. So, make sure you have a plan A and B. As an example of this, I had a patient coming from one of our hospitals, and the helicopter was booked. They tried Mayo, they tried North, Medlink, they were all busy. And on our end, the ECC, the Emergency Communication Center, spent so much time trying to locate another air ambulance. They never really thought about the fact that they could just load and go, you know? So, and that was our side and the hospital. It's like, okay, let's think about what we're gonna do. What is our plan if we don't have air, if we can't fly? What is our plan if we can't, you know, get the patient out by ambulance right away? Some of the things that you could think about is, obviously, if air is booked, go by ground. If you can't go by ground, then are they eligible for lytics? Can we give them lytic therapy? Know what you're gonna do in these situations, because the weather in Minnesota and Iowa is terrible. And I hear this winter's gonna be even worse, so. Obviously, time matters. I think I've tried to explain that here. I believe that you all understand the complexity. I'm just gonna show you some statistics. Statistics are kind of boring, I know, but so patients that are meeting the goal, the percentage, 2.2% death rate versus 5.7% when they go beyond the recommended guideline goal. This is taken from the Action Registry, which is part of the American Heart Association. It's Mission Lifeline's national initiative to improve donor balloon time for transfer patients, help with EMS collaboration. So these are transfer and non-transfer patients. So in the green is donor balloon time for patients that present to a PCI hospital. So if they show up at a hospital that has PCI. So you can see the quarters are on the bottom, so quarter 1, 2, 3, so on and so forth. And you can see that there's relatively no change in the donor balloon time. So as a community, we've come to realize there's not much more work we can do with our own PCI centers. There's, you know, we've done as much as we can in meeting the donor balloon goal for that. But for transfer patients that are coming in either from EMS or from referral hospitals, the time goes up dramatically. And it's not improving drastically. So we're kind of a holding pattern, and we're really working hard at trying to help develop tools to get patients in and out quickly and get them to where they need to be. We're not meeting the goals that we need to meet for transfer patients. Some of the predictors of long door to balloon time. Obviously, I talked about this. Patients that don't call 911, they typically have a longer door to balloon time. If they present during off hours, there's not as much staff. There's just not the resources that we need. If they're not stable, they come in hemodynamically unstable, and you have to, you know, do more tests if they're coding. Obviously, there's multiple things that could be going on that aren't going to be working well. Older age patients, females, we talked about that too. Distance and weather, so know your plans. What are you going to do if, you know, the weather's bad? And those are things I talk about and report, you know. What are we going to do tonight if helicopter can't fly, we have a chest pain patient? What are we going to do? What if we have a stroke patient come in and they can't fly? You know? Trauma, I mean, just the list goes on and on for you guys. So some of the things that you guys can do to help expedite the transfer of these patients. You know, promptly identify the patients at the door when they're coming through. It's a little bit more complex, as we talked about, because you guys don't have somebody sitting there, but as I came in, I noticed that if it's off hours, I assume you have to phone in, right? So you're gonna meet the patient typically, and that's the same. And then also to recognize the symptoms and be able to get that ECG machine there quickly. I don't know if you guys have an ECG machine in the ER. You hook them right up to the monitor. So that's good. And everybody knows how to put on a 12 lead or whatever. And then, do you have a STEMI protocol here that you follow? So you have a step-by-step deal, and does that include lytic or no lytic? Does. And then just empowering you guys to make decisions to help the physicians. As a nurse myself, I know that they're not always here. You guys, I feel like nurses have the ability to, their instinct is so powerful, and they know, like, we've just seen so many things, and we know what's going on. And so, do you guys have, moonlighters, or you all have, do you have staff consultants that rotate?
We have staff and we have some that come in.
Locum providers?
Yeah,
Okay.
but mostly.
Yeah, so especially with your locum providers, that's where I think you can really help knowing the protocol and knowing what to do, because they're probably not gonna be on top of it like you guys are. Time savers for transport, I don't know how much you guys do here, or what your typical process is, but some of the things that we've identified is, you don't need to have the drip running. Depending on transport, you don't necessarily have to have the nitro running. The heparin, we kind of, we've slightly went away from having the heparin running, because what happens is when they get loaded into the helicopter, they typically have to switch everything over anyways, and by the time the helicopter gets to the PCI center, they've only gotten a very small amount of the heparin, and then we end up giving them more heparin when they get there anyways, because we monitor their ACTs. So the first thing we do when they get to the lab is we draw an ACT to see what their clotting time is, and we'll give them more heparin. So depending on distance the patient has to travel, that's one thing that you can do, is not have to switch over all those pumps. Minimize the time at the bedside. When the transport team gets there, you want to have that patient as ready as possible, so that they can just load and go. We expect our transport team to be able to be on scene and out the door within about 10 minutes. So similar to what we have for trauma. And I said this before, don't delay waiting on the patient records. Just send those later. You don't have to necessarily have that all ready when the patient's leaving. This is the metrics that we are